Hello. So we start about instruments now. Orthopedic instruments and orthopedic implants are expected MCQs. In May 2017, they started this trend and it is expected to go on. Let's start with the general instruments. The first instrument that I want to talk about is a bone nibbler. Bone nibbler nibbles the bones in the soft tissues. You can be asked to identify either a straight or a curved bone nibbler. It's at the tip. They take out the punches of the tissues. So the first instrument is the bone nibbler. Along with it, to cut the edges of the bone or the osteophytes, when osteoarthritis is being dealt with, you have a bone cutter. Bone cutter. It is also used to make small fragments of the bone grafts that you obtain. Bone cutter. Then, to freshen the bone margins or to raise osteoperiosteal flaps, you have an instrument called as a chisel and an osteotome. In a chisel, only the one edge is beveled, means it is sharp only from one side. So that's how I used to remember C. Chisel C, so one cutting edge. Whereas in osteotome, both the edges are beveled. So C, other side also C makes a O. So it has got both the edges sharp or beveled. It is high likelihood you will get osteotome. Chisel is a rare question to be asked. Then we have a bone mallet or a bone hammer, which is used along with the chisel and osteotomes in orthopedic surgeries. Bone mallet or a hammer. Periosteal elevator. This is used when you need to expose the bone either for plating or any other surgery. Periosteal elevator. Bone curette. It can be used in cystic cavities where you need to do curettage. It is also useful when sometimes you have to remove a very small amount of cancellous bone graft. But usually for bone grafts, we have the bone gouge. After exposing the iliac crest, this gouge is run or an osteotome is run to take out the slivers of the bone graft. When you are doing any orthopedic surgery where the fixation of an implant is required, then that can be done with the help of a bone lever which can extract out the bone out of the depths inside the muscles and the soft tissue planes. There are different types of bone levers and different shapes. Then, when you are trying to fix up a bone with a plate, you need to make the holes. For that, you have an instrument called as a bone tap. Bone tap basically drills out the threads in the bone in which the screws will lock. Let's talk about some pins and nails. You can see three instruments here. At the top, this is a K wire. A K wire or a Kirschner wire is sharp at both the ends and is used for fixation of small bones or bones in children around the joints. Then we have a Steinmann pin. A Steinmann pin is used for skeletal traction. And then if the bone is osteoporotic or you have to put skeletal traction in a weaker area, then you have a threaded pin in the center called as the Denham's pin. So this is a Steinmann pin. It does not have any thread. Its two important uses are it is useful in skeletal traction and also for compression arthrodesis above and beneath a joint which requires fixation, fusion. These are the threads in the Denham spin, which is used for cancellous bone or for the osteoporotic areas. Bowler stirrup is used to hold the Steinman pin or the Denham pin so that subsequently the traction which needs to be applied can be tried here along the bed edge. Bowler stirrup. We have two nails in upper limb, one for the radius, one for the ulna. These nailings are not very commonly done nowadays because nowadays is a trend to do plating of forearm bones. But this is a bend in the radius nail which helps it to identify as compared to a straight, square ulnar nail which does not have any bend. Then we have a rush nail which is bent at one edge, which is used for fixation of the long bones, mainly in children, and the bent edge is there so that it stays along the cortex of the bone to prevent its migration into the intramedullary cavity. Kunsher was a great scientist who devised nails for the long bones. He devised a nail for the femur and also for the tibia. Kunsher's nail is a clover leaf intramedullary nail because the shape of the nail in the cut section is like a clover leaf. This nail works on 3-point fixation. When put in the intramedullary cavity, it provides fixation at the two ends and the isthmus, the narrowest portion of the femoral canal or any bone. K nail has a disadvantage. The disadvantage is it does not protect against the rotational instability because the nail is not fixed to the bone. For that, later on, we have devised interlock nails. Interlock nails are the nails which go inside the bone and then subsequently are locked with the screws to the bone to provide a stable fixation, more importantly, rotational stability. Nowadays, for the proximal femoral fractures, specifically the intertrochanteric or the subtrochanteric fractures, we have the fixation called as the proximal because it's in the proximal part of femoral nail. This has replaced dynamic hip screw practically for intertrochanteric fractures in today's world. Then, in older times, not preferably used now, Austin Moore pins were used for fracture neck femur in children. They had a locking mechanism preventing the pin to migrate inside the joint. Austin Moore pin for fixation of the neck femur in children. Let's talk about some important forceps. The first one being the bone holding forceps. When you have a bone holding forceps, it has a quality, it has a threads in it. These are the threads which will help you to hold the bone. And this was the forceps which was asked in AIMS May 2017. This is self-retaining bone holding forceps. Self-retaining because this locking mechanism will hold the forceps and hold the bone pieces together for a reduction during the fixation of a bone. Then further, previously we had these type of forceps for bone holding. The Ferguson bone holding forceps. They again have a tooth, and the Lane forceps, which again has tooth at the ends. So what I want to tell you, whenever there are tooths, they are holding the bone. And then we have a Lawman's clamp, which is also used for holding of the bones along the reduction, right? Lawman's clamp. We talk about another thing called as a bone plate holding forceps. Sometimes it is grossly said as a plate holding forceps. Plate holding forceps at one end will not have threads. At the other end, because it will hold the bone along the plate, right, will have threads. That's why called as a bone plate holding forceps. Bone because the threaded end is there. Plate because the smooth end so that the plate is not eroded or corroded. Then we have simple sponge holding forceps, which are used when we are doing painting and draping. And we have the Alice tissue holding forceps required for traction or retraction along the surgeries. We have tooth and non-tooth forceps for doing the fine work. Tooth forceps are used to hold on the tissues which are deeper, and non-tooth forceps for the superficial tissue so that the skin is delicately handled. We have retractors, the right angle retractors for the assistants to show the main field and retract the tissues, especially the muscles which are there in the orthopedic surgeries. Then we have an important traction which I believe this year can be a question, Crutchfield tongs, which are applied in the skull for traction of cervical spine. Applied in the skull for traction of cervical spine. Crutchfield tongs. Then we have an external fixator called as an Ilizarov fixator, which is a ring fixator, which will hold the bone in a very stable position. The indications of Ilizarov are to lengthen the bone or the limb, used in infected non-unions or gap non-unions, because it works on the principle of distraction osteogenesis, lengthening at the rate of 1 millimeter per day, and the limit up to each bone has a separate value to which you can lengthen. Ilizarov fixator, a very important fixator. It's a variety of external fixator because the fixator is outside the skin. Let's look at some important features of a classical external fixator. We have already done this, that this is a denim spin. This has got thread. This is for traction. But if you have threads at the end, this is called as a Shan's screw. And this Shan's screw has a T handle and a Jacob chuck, which is used to hold a screw to be put inside the bone. Then we have got the connecting rods and the clamps to make an external fixator assembly. To make an external fixator assembly, these are the Shan's screws which have been put in the bones. These are the universal clamps which are there, and these are the connecting rods. And since the fixator is outside the skin, it is appropriately labeled as the external fixator. Then we come to the prosthesis. Prosthesis means replacing the body part. Till now we were doing surgeries which are fixing it. They were fixation. We talk about prosthesis. The classical prosthesis, that is hemiarthroplasty, means replacing half the joint, is called as Austin Moore or Thompson prosthesis. In Austin Moore prosthesis, we had two fenestration, two holes. To remember, in Austin Moore, two O's come together. They come together, so there are two holes. Thompson is a hemiarthroplasty replacing half the joint, but there are no holes. Remember, it also has two O's, but two O's are not together, they are separated out. In Austin Moore, they are together, so they are for fenestrations, two fenestrations, Austin Moore hemiarthroplasty. When we have bipolar prosthesis, Austin Moore and Thompson are unipolar because they don't allow movement inside. Talwarkar made a prosthesis which was bipolar. But then we have modular bipolar. In modular bipolar, you can have movement of the acetabulum, the cup and the acetabulum, and the head and the cup. So they allow movement at two places. The head inside the cup of the hemiarthroplasty and the cup in the acetabulum. You can also control the sizes of the implants in modular bipolar. Nowadays, when we do hemiarthroplasty, we usually do modular bipolar. Modular because each one has a different ratio of head and the neck length and the sizes. So it allows a better stable joint to be applied and better length of the neck to be achieved for a good functional liver arm for abductors. Modular bipolar. Also, when we do a hip replacement, Then there can be two varieties. One, a cemented variety, where the implant is held to the bone with an intervening layer of cement, which is usually polymethyl meth acrylate. And sometimes you can do a fixation which is directly coating on the implant. The metallic implant allows the ingrowth of the bone over the implant, making it more stable. It is called as uncemented replacement. Uncemented replacement is stronger, is costlier, has a longevity which is more than cemented replacement, and is preferable for a patient who's got a normal bone quality or a younger patient. Whereas cemented replacement is usually carried out for people who are elderly, who have weaker bone stock, because here the cement will immediately provide stable fixation along with the implant, whereas an uncemented requires growth of the bone over the porous coating of the implant. This is what the hip prosthesis is consisting of. We have a femoral component in the femoral canal. We have the head and the neck in the center. We have the cup and the acetabulum at the top. This is a total hip replacement. Between the head and the cup, there is a lining, usually of polyethylene or any other material as specifically required. This is total knee replacement. In total knee replacement, we have a femoral component, we have a tibial component, we have the intervening plastic spacer which substitutes for the meniscal layer in between, and then we have the patella which is replacing the patella for the patellofemoral articulation. This is total knee replacement. I believe they can ask you any component out of it. I'm telling you two more varieties of replacement, although rarely done, but you must know the implants. This is ankle replacement, basically replacing the lower end of tibia and the upper surface of the talus. Very rarely done surgery, but still done. This is total elbow replacement. This has got a component that fixes into humerus and the other one into the ulna. Total elbow replacement. Let's talk about some plates. When we look at the plates, one of the classical things that I want to talk about is a dynamic hip screw with a plate. You have a screw that goes inside the head of the femur, and then you have a plate with a barrel which slides on the screw. It allows controlled collapse at the fracture site, and that's where the screw moves along with it, called as a dynamic hip screw. A screw in the center of the head of femur with a good tip apex distance. Tip apex means the distance between the head of the femur, the articular margin, and the tip of the screw. If it is appropriate and it's holding onto the strong, deeper bone, this is a very stable fixation. It was classically called as a treatment of choice for intertrochanteric fractures. But as the science evolved, this surgery had complications which were discovered. So gradually now, proximal femoral nail has replaced many indications as a treatment of choice for intertrochanteric fractures. If they say it's an undisplaced intertrochanteric fracture, simple two-part, then still you can choose dynamic hip screw as a treatment of choice. But for practically any displaced intertrochanteric or subtrochanteric fracture, comminuted fractures, or a reverse oblique fractures, now the proximal femoral nail has become the treatment of choice for the proximal femur fixation. Then how the surgeries evolved. The first surgery was dynamic compression plate for plating. Dynamic compression plate, as the name says, it was a fixation method where a plate was put over the bone. The bone was exposed in total, and then you were putting screws to hold the plate. If you put a screw in the center of the holes, suppose it's a fracture site here, then this is called as a neutral plate because this is simply holding on. But when you put one screw in the center and other at the edge of the plate, and when you tighten the screw, then the plate, when they will tighten the screw to create the space, because this screw has already fixed the bone, then when you tighten the screw, it requires some displacement of the plate on this side. That's how this fracture side gets compressed, because this plate and the bone here on the side where the normal screw has been put, they will slide together to compress. That's why it's called as a dynamic compression plating. In dynamic compression plating, you put a screw in the center, and on the other side you put an eccentric screw, so that it slides the bone and plate, causing compression at the fracture side. Now dynamic compression plate provides this dynamic compression at the time when you're fixing it. It is not something which is dynamic throughout, like a dynamic screw where the dynamicity is when the bone is uniting. Then subsequently what we realize in a dynamic compression plate, because when you were fixing it, right, you were exposing the entire bone, so there was compromise in the vascularity. So as science evolved, we were trying to preserve the biology. An attempt towards the same was creation of a limited contact, LC, limited contact dynamic compression plate. In this, there were grooves beneath the plate. These grooves were allowing the vascularity or the blood vessels or the periosteal vessels to creep in beneath the plate and to preserve the vascularity of the bone. So gradually, LC-DCP replaced DCP in most of its indications. But there was a problem. Both the plates, the DCP and LC-DCP, if you use them for a long time or in the weaker areas or less number of screws, there was a problem that the screw would still come out because it would not hold on to the plate very strongly. So how to help it? To help it, they came out with a new solution where they gave a combo hole in the plate, or they made threads in the holes of the plate and the threads in the screw, where the screw will lock with the threads in the plate. In the combo holes, also one of the screw was threaded, hole was threaded, and the other hole was unthreaded. So you can use it as a classical DCP or LC-DCP as well, or you can use it as a locking plate where you will drill a hole into the area where the threads in the hole are available. Locking plates are used in metaphyseal areas. It is held in osteopenic bones. It is used for periprosthetic fractures. It is also used for prolonged fixation when there is non-union. So it has 4 indications. And going further, we have one more plate where I want to talk about is a reconstruction plate. It has a different shape altogether. Locking plate, dynamic plate, and a reconstruction plate which has a power to mold and is very commonly used in areas where you need to change the shape. For example, in acetabular fractures, right? Reconstruction plate. It can be locking, it can be normal plate without locks. These are 2 types of screws, the cancellous and the cortical screw. The difference between the two: the cortical screw has a bigger central diameter, the root diameter, but the pitch, that is the distance between the consecutive threads, and the depth of the threads is less, and they are usually non-fluted. But in a cancellous screw, although the root diameter is less, but they have more pitch and more depth. So they are used for cancellous areas, right? And also one more hint, although cancellous screws can be fully threaded, but usually when they will show you a cancellous screw, they might show you partially threaded, but it can be fully threaded also. Thank you very much. Here we complete our talk on instruments. If you require anything else, please write to us or talk to us on WhatsApp. Please subscribe to our channel, MedMiracle. medmiracle.in@gmail.com is the email ID for any queries you have. This is the WhatsApp number. Feel free round the clock to drop in whatever you need. We're always there. Thank you very much. Happy listening from Team MedMiracle. Thank you very much.